Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us today for this informative webinar, providing effective, risk-managed treatment for potentially suicidal patients in outpatient private practice, being held with our valued partner, Camscare. The Trust is pleased to be able to offer this type of content free of charge to our policyholder. In addition, I wanted to make you aware of a special 20% discount we've secured for you through our partnership with Camscare. This exclusive savings can be used on any Camscare training products. For details, please visit parma.trustinsurance.com and select the Independent Learning tab. From there, select Camscare. Today's webinar is being presented by Drs. Eric Harris and David Jobs. Some of you may know Dr. Harris as a risk management consultant for the Trust Advocate 800 program. What you may not know is that he actually started our risk management program in 1994. Dr. Jobs is a legend in his own right and is one of the foremost experts in the field of suicide, having begun his research in the early 1980s. I hope everyone learns a lot over the next 2 hours. You're in for a treat from two wonderful presenters and experts. Please join me in welcoming our esteemed presenters. Gentlemen.
Well, thank you, Jana. This is Dave Jobs speaking to you from my study in Bethesda, Maryland. And I'm so delighted to be a part of this event this evening with my old friend, Dr. Eric Harris. The goal here is to really combine resources of the Trust and the way that Eric thinks about risk management, how the Trust approaches this, along with our focus specifically this evening on clinical suicidology and some of the research that informs our discussion. So without further ado, I'm going to share my screen and dive on in. The presentation is available as a PDF, as Jana said, and you'll be able to access that. So I trust that this is showing as desired. I'm going to take the lead in a lot of this. Eric has specific sections that are clearly in his wheelhouse. I think the two of us are going to be interactive around certain points as well. We've got plenty of time to work with here. We will be taking questions in the last half hour, and we really look forward to that exchange with you all as members of this audience. So Dr. Martin gave us an overview of the presentation and a little bit about Eric and myself. Maybe just to add a little bit more with regard to myself, and Eric might do the same. I'm in private practice, so I see this. I was a senior partner, group practice in Washington, D.C. for about 20 years, and I have a small practice as well. I'm a professor of psychology at Catholic University, and I'm an associate director of our clinical training program, which is an APA accredited program in Washington, D.C. I have taught ethics for about 20 some odd years, and I'm married to a lawyer. So I think a lot about these issues from a legal perspective, and I've served as an expert witness on plaintiffs and defense cases, and that will certainly inform a bit of what I have to say as we progress this evening. Our learning objectives are to identify current practices. So we kind of want to talk about where things are and what people in general practice think to do around suicidal risk. We're going to describe risk management strategies when dealing with suicidal patients. This is tilted towards CAMS. We're co-sponsoring the event, but I'm going to be speaking broadly to other evidence-based approaches and what we know from the research literature actually works in a causal way. So we're going to identify risk management and clinical benefits of integrating empirically validated screening and assessment techniques to an outpatient clinical practice. I know as a practitioner, even in a group practice, it can be really lonely sometimes, different from working in a multidisciplinary treatment team. And so I think for those of you that are in private practice, this might be an especially relevant evening. We're going to talk about CAMS a bit in context. We're also going to use it as an example, illustrating some of the key points that Eric and I will be making. It's not the only way to approach this, but it's one that obviously we're going to speak to and that you might be interested in following this presentation. And we're going to identify ways of training and certification in evidence-based treatment that can help your viability. There's a lot of clinicians that try to avoid suicidal clients. If you get the knack for this and really get the hang of an intervention that's effective, this can be actually a big part of your practice. And I hope to make that a compelling case, that you can actually expand your practice if you're willing to see these clients, because a lot of people aren't. And we're going to try to address that through the course of this evening. Our agenda, suicide is a mental health care crisis. We'll be talking a bit about management of risk, current practices. We're going to talk a lot about hospitalization this evening and what people think about that, and what how people might practice defensively, which I'm going to talk about. Is that in the patient's best interest? And we got to think about those kinds of things. We're also going to talk about ethical and legal considerations, obviously, evidence-based approaches and how to integrate them into your practice. CAMS will be mentioned, obviously, as an illustration, and then we'll end with a bit about integration and managing and developing your practice, to be followed by questions and answers. So without further ado, let's dive on into the content. I'm going to take a bit of a lead here, talking about the challenge of suicide in the United States, which has been a persistent and stubborn public health issue. If you're not familiar with the literature on leading causes of death, we're all pretty preoccupied with leading causes of death these days in the midst of the pandemic. We see that when public health attention and research dollars are turned towards our major leading causes of death, like infant mortality, influenza, tuberculosis, HIV, that we can drive down these death rates. I think of when I was first in graduate school, and HIV and AIDS-related mortality was spiking in the 90s. It was a death sentence until the NIMH appropriated billions of dollars in perpetuity in HIV-related research. And now we see it as a chronic illness that can be managed through medications. So it's not just the money, but it is a public health focus and attention, and the research that drives down these leading causes of death. And then we look at suicide, and we notice that that line, that red line there, just kind of keeps on creeping up. In the late 1990s, we had hopes that we were turning a corner and driving the numbers down. And then really since the early 2000s, we've just seen a gradual climb. And that's discouraging, even though there's been a lot more public attention and public health attention and media focus on suicide and increased dollars for research. We still don't see a commensurate level of funding for research that would maybe help turn the tide. So in total, we're talking about 48,000 deaths. Now, there's always a 2-year lag in the National Center for Health Statistics reporting on all of our deaths, including suicide. So 48,000 is the rate that we have for a couple of years ago. More recent data from SAMHSA, the health organization for the federal government, 1.6 million attempters of adult Americans every year. This is in 2019 data. A number I'm going to be preoccupied with this evening, 12 million adult Americans with serious suicidal ideation. So that's the prompt from the SAMHSA survey. And if we include children and adolescents who are obviously suicidal, including children down the age of 4 or 5, we're probably looking at a much larger number of people that have serious suicidal thoughts. So what are the current practices as we understand them? And how do we kind of approach that? What is typically done, and what do people do, or what do they know they should do, but maybe not get around to doing? And those are the kinds of things that, that Eric and I will certainly be drilling down on. What we know from the survey literature, and this is not a super exhaustive literature, is that most clinicians, we did a survey study back in the 90s, but I think the data holds up fairly well. Most clinicians ask about suicide risk through interview and do not necessarily rely on a reliable, well test constructed assessment tool. There is extensive research by Paul Meehl, who was a late professor at the University of Minnesota, talking about clinical judgment versus actuarial assessment, and clinicians being very confident in their clinical judgments, their gut judgment, when assessment tools invariably do better. As psychologists, we want to, I think about the psychometrics of any assessment approach. And if you think about this from a risk assessment standpoint and a risk management standpoint, your clinical judgment can be meaningfully supplemented by an assessment tool, and you're adding further documentation to the medical record progress notes. As Eric is going to speak to, documentation is a really key player in risk management. So we know that clinicians mostly rely on observations and questions. We know that there are a number of clinicians that avoid talking or asking about suicide risk. We know from one study that was published 2 years ago that there are patients who avoid talking about suicide risk because of fear of being hospitalized. So we have a bit of a standoff and a bit of a dance around this topic. And so one of the things is, how do we meaningfully engage on this sensitive topic? For some people, very ashamed to acknowledge these feelings. For clinicians, maybe really afraid to ask, kind of a don't ask, don't tell approach. So what we would advocate is that you do have a reliable way of assessing suicidal risk. The ones that are widely used, if they are used, are probably the PHQ-9 and the Columbia Suicide Severity Rating Scale. The reason these are probably the most widely used tools is that they're free. So you can get them off the internet. They're non-proprietary. The PHQ-9 is actually a depression screener that has this imperfect question number 9, thoughts that you'd be better off dead or hurting yourself. It's a conflated question. It doesn't ask directly about suicide risk. It was not intended to be a suicide risk screener, but it is used in this way. And Greg Simon out in the Kaiser Permanente system has done some really interesting research with tens of thousands of patients in their healthcare system, showing that the PHQ-9 question actually does have some value as a screener. Sensitivity and specificity is not great, but it's better than nothing, would be one argument. It's a standardized screening tool, and Greg Simon's work does say there's virtue in asking that question number 9. From a psychometric standpoint, the reliability and validity, we're going to struggle with that. We're going to struggle with that with all of our assessment tools. But these free ones are compelling because they're available and they're non-proprietary, obviously. The next one here is the Columbia Suicide Severity Rating Scale, or CSSRS. The Columbia is oftentimes referred to, developed by Kelly Posner and a number of luminaries in the field of suicide prevention. It is also available online. It was actually a tool that Kelly developed for the FDA trials looking at the serotonin selective reuptake inhibitors, the SSRIs. I was on one of those adverse event studies where we used the original tool to look at adverse events related to the medications. And Kelly converted it into a clinical tool and then played a little bit of catch-up ball in terms of getting the psychometrics, which actually have gotten better and better with increasing iterations. And so it's available in this form. There's also an online version of it that is proprietary, but has kind of an elegant online presence. My personal favorite among the non-proprietary is the ASK, the Ask Suicide Screening Questionnaire developed by Lisa Horowitz, who's a research scientist at the NIMH. So our taxpayer dollars paid for this. The ASK was originally normed on a pediatric sample in a youth sample. So it works with children and youth, but it also works effectively with adults. In Psychosomatics just this year, Lisa published a paper that we helped collect data from at Walter Reed National Military Medical Center to get normative data psychometrics on the validity and reliability of the ASK. It's a simple 4-question screener with a follow-up question if there's an affirmation. It's used in medical surgical environments, and it's been used now with children, adolescents, and adults, and military samples if you're interested in that population. So these are the free ones. You can get these online off the internet. The ASK, I think, has the most robust psychometric properties, but it's obviously got a lot of face validity. There is, and that's always a conundrum here, because some patients want to be seen as suicidal and others don't want to be seen as suicidal. So the validity issues around this are very tricky. So there's a lot of interest in the field of suicide prevention looking at implicit association tests, eye blink tests, different physiological tests to try to detect somebody who's really suicidal, who's denying being suicidal. But in any event, there are hundreds of assessment tools out there that people can use. I would strongly recommend that you consider using at least one of these, if not other assessment tools, if you're so inclined. It adds medical record documentation. And usually, if it's done correctly and empathically, it can be a positive experience for the patient as well. Another big sort of development in the field in the last several years has been the development of stabilization planning. The most probably famous being Barbara Stanley and Greg Brown's safety plan intervention, or the safety plan as it's sort of generically referred to. This is the remedy to the no suicide contract. No harm contracts have been proven in clinical trials to not be effective. In comparison to the safety plan, in a cohort comparison trial in the VA that was published in JAMA Psychiatry about 2 years ago, significantly better than no harm contracts or no suicide contracts. And the second one here is called crisis response planning, developed by David Rudd and Craig Bryan. And this was conducted or studied in a randomized controlled trial with a military sample and published in the Journal of Affective Disorder. Craig Bryan was the lead author on that and saw a 73% reduction in attempt behaviors by a one-touch crisis response plan intervention. So the clinical trial data is clear. If you're using no harm contracts or getting people to commit to their safety, stop it. At least I would say stop it. I'm sure Eric would agree, because we want to focus on what the patient will do should they get in a dysregulated acute state versus what they won't do, promise what they won't do. Years ago, Lillian Range did a really interesting study on safety, on no harm contracts, and showed in a sample of clinicians and patients that they were highly effective in making the clinician feel like they had done something effective. The patients hated them. They felt coercive, they felt invalidating, they didn't like them because they're promising, I won't kill myself, and if I won't promise you and sign your form, then you're gonna put me in the hospital. It makes no sense. It never made sense to me. These, in contrast, are looking at warning signs, different ways of coping, people to reach out to. The safety plan has a 6-step version of this planning for safety. The crisis response plan is very similar, but it's done on an index card where the patient writes out in their own hand on an index card, and then they laminate it for the patient to carry it around with them for use in a crisis. So it just makes so much more sense than getting somebody to promise that they won't do something. When they get in highly dysregulated states, they're going to do what they're going to do. But if they're properly introduced to these interventions, they may pull these out and indeed use them to get through a suicidal dark moment. Another major emphasis in the field, at least, and hopefully in your practice, is an awareness and raising awareness to your clients about the National Lifeline. SAMHSA underwrites the National Suicide Prevention Lifeline, and the number is 1-800-273-TALK. That rather unfortunate number is going to be replaced in 2 years' time by 988. So not to confuse things, right now, the number is 1-800-273-TALK, but legislation just passed this year to make it a 3-digit number in the summer of 2022, I think, in a couple of years. So that's going to create capacity issues, but it's going to be much easier to remember, and you're going to see the big rollout of 988 in the next couple of years. The Suicide Prevention Lifeline, I'm on the steering committee. I co-chair the National the Standard Training Practice board of the Lifeline to get up to standards. These are people who are paraprofessionals, who are extremely well trained, who are used to talking to suicidal people, and they're good at it. And Maddie Gould at Columbia and John Califat when he was alive, and Brian Mishara, who's a Canadian psychologist, have done research on the Lifeline and shown its efficacy. So we know the Lifeline is effective, and we know that patients are responsive to it. An alternative is the National Text Line, which is 741-741. And you can Google these and find these. They're well publicized. The text line is a privately funded crisis information for people that would prefer to text. And so these are great resources that your clients absolutely should know. We're going to talk about whether you let clients or have clients call you between sessions if they're in crisis. That's always controversial, but at a minimum, they should have access to these kinds of resources. Another big focus in the field is called lethal means safety. We used to call means restriction, but that got gun people upset. So lethal means safety is the sort of the new way of describing how do we reduce access to lethal means? How do we negotiate that with clients to ensure that the environment that they're in or that they're returning to is less dangerous? So, hospitalization. It's not always the best intervention for suicidal states. I think from a defensive practice standpoint, Eric and I hear a lot of, better safe than sorry. I would hate to take the risk of working with somebody on an outpatient basis, only to have them kill themselves, and then I'm going to get sued for malpractice wrongful death. That's possible. Anything's possible. But especially during the pandemic, we have to think about the virtue or the morality even, or the ethics of routing somebody to the emergency department when right now they're being overrun by COVID patients. What are the challenges right now of having somebody go to an inpatient unit where exposure and PPEs, may or may not be available, both for staff and for patients? So we're going to talk a lot about this. I know Eric is going to dive in on this, but here's the data. The majority of suicides occur within 1 month after discharge. So when you look at, for example, survey data about typical inpatient care, and I'm a big inpatient guy, that my whole early career began in an inpatient unit. What's mostly done is prescribing medications. And medications have limited impact on suicide risk, and I'll address that as we go. Really, it's the psychological treatments that are most effective. So they're there typically for 5 or 6 days. The modal stay might be 2 or 3 days. And they're mostly getting medication, and they're mostly hanging out. They might go to 2 or 3 groups that, according to survey data, this is data that is readily available, they don't find the groups especially helpful. And then the utilization review people show up and are trying to get the patient out the door because they've been there for 4 or 5 days. So really, how is that therapeutic? They've been removed from their job. They've been removed from school. They're in an environment, and now post-discharge, and this has been replicated around the world, there's increased risk. We're not going to say that hospitalizations cause suicide. Now, there's an Australian psychiatrist named, it'll come to me, but he talks about nosocomial suicides. Matthew Large, and Dr. Large, very controversially, will say that there is a subset of suicides that are caused by the inpatient hospital stay. Now, you can imagine how popular he is among psychiatrists. But his argument is that there's a lot of iatrogenic effect in some contemporary hospitalizations. We know the rates are significantly higher, and this has been replicated. Michael Bostwick published a study from the Mayo Clinic showing that a single hospitalization increases lifetime risk for dying by suicide. It's correlational data, but significant correlational data. Compliance with routine discharge and outpatient care is abysmal. Less than 40% attend a appointment that's been made dispositionally. And many patients just go back home. And now they're really discouraged because they've gotten the kitchen sink, the most expensive and invasive intervention we've got in our field. And they were there for 4 or 5 days. And to varying degrees, they may feel that nothing really effective happened. And now they're back right where they started. Now, there are remedies to this. There are interventions that can be done while they're on the inpatient unit. I'm talking about the modal hospital experience in the United States. So we got to be thoughtful about how therapeutic this might be. Very few attend their outpatient appointment. So again, I would still contend, and will always contend, that there's a place for inpatient care, but it should be the last response, in my view, versus the first response. And Eric and I will talk about that, I'm sure, as we go. The other thing I want to emphasize as I transition here towards Eric is really the importance of suicidal ideation. When you look at this SAMHSA figure, your eyes are drawn to these colored bubbles where people attempt or make plans. And what you might not be attracted to or drawn to are the 12 million people in the gray circle which is a massive population. It's 225 times greater a group of people than people who die by suicide. So we're very preoccupied with behavior. And in the field of suicide prevention, I've had papers rejected because we've only reduced suicidal ideation and didn't necessarily change attempt behaviors. But only reducing ideation, that is a lot of people. And when we look at this and think about this, I wrote an editorial with Thomas Joyner in the journal Crisis that we see lots of cognitive changes in things like OCD or in psychosis or bipolar disorder with no behavior change. And we call it a big clinical win. But when we see cognition change with suicidal people, it doesn't count unless we're reducing behaviors. And my argument would be the iceberg of the suicide problem are the people with serious suicidal ideation. And yet in the UK, you can't get dialectical behavior therapy unless you make a suicide attempt. My colleagues there say we're operantly conditioning patients to make suicide attempts so they get DBT. Because if you just have suicidal ideation, you get supportive counseling. Makes no sense to me. The suicide problem is an ideation problem. And if we were better at treating ideation upstream, we'd have fewer attempters and fewer completers. We also know with the advent of the pandemic, with SARS-CoV-2, that we've got mental health issues like crazy. And even though all this has been politicized, we know that 40% and more are struggling with mental health issues and substance abuse. And we clearly know that the suicide ideation levels are up. We don't know if completions are up. They are apparently in Japan and in South Korea. But last I heard, they weren't in Australia, where they have better reporting, more timely reporting. So just because we have ideation up doesn't mean we have completions up. We'll know in 2 years. Some of us had thought there might be a resilience response, that there can be in some crises that may wear out and we might see a spike. So the data will be forthcoming in the years to come. So treating ideation from my vantage point is really huge because it's such a big population. And again, we can't hospitalize 12 million people. And hospitalization isn't necessarily addressing suicidal ideation because hospitalizations are mostly focused on mental disorders, thinking of suicide as a symptom, where the effective treatment doesn't focus on the disorder, it focuses on ideation and behavior, independent of the diagnosis. So that's what the data in the randomized controlled trials tell us. So, we have to think in context in a contemporary way about what treatment is. Now, I'm a big fan of the work at the Menninger Clinic, where patients are hospitalized for 50 to 60 days. That's a really unusual place, and it's very, very expensive. So what's typical are very brief stays. Last time I hospitalized a patient, she was hospitalized overnight. And the next morning when she saw her attending, he said, next time you feel like overdosing, just don't do it. And she said, okay. And the social worker contacted me to have her discharged back to my care. So, when you have a couple of those experiences, it makes you a little bit cynical about the virtues of inpatient care. So let's now sort of move into this discussion that's going to bring in Dr. Harris. I'm going to give a little bit of my overview. This is actually inspired by a workshop that Eric and I did many years ago, a workshop at the American Association of Suicidology, where we talked about malpractice and how to think about this early on. It led to a paper that was published by myself and Lanny Berman back in 1993 in the journal Professional Psychology Research and Practice, where we identified what we call the 3 pillars for reducing malpractice liability. So if you're not familiar with malpractice, it's a wrongful death action. The plaintiffs are typically families and loved ones. It's a tort action, and the burden of proof is on the plaintiff. Wrongful death by surviving family members will be argued that you didn't meet the standard of care, that you breached the standard of care. Acts of omission or commission were a direct or proximate cause of this bad outcome, in this case, this fatal outcome. Standard of care is operationally, and Eric might correct me on some of these things, an operation defined by experts, people like me, who lawyers on the plaintiff side and the defense side hire to go over the records and go over the briefs and the depositions to judge whether the person met the standard of care. What would a reasonably prudent practitioner with a similar patient in similar settings have done? So experts weigh in. It's kind of embedded in every case. There are interrogatories that people don't respond to. There are records are subpoenaed. That's a very unpleasant experience. And there are depositions. The plaintiff has the burden of proof, so they have to really get over the bar of burden of proof to establish that there was a failure to assess, which we call foreseeability, a failure to appropriately treat the risk, and a failure to follow through, or you drop the ball, that this person fell through the cracks. Documentation is really critical in terms of your best armor for protection from exposure to liability. And as we'll get into this, CAMS kind of does it for you by the way that it's constructed, and the medical record is part of the engagement process. So with that, I'm going to introduce Dr. Harris, who's going to take a lead here on guidance from the trust. Eric, take it away.
Okay, next slide. So before I start, I want to say basically that most of my experience that I'm going to be talking about comes from doing risk management with people in outpatient practice. Now, outpatient practice and inpatient practice are very different things. And so the risks of things are different. But traditional what I would call old medical malpractice theory is when you're an outpatient mental health provider faced with a patient with a moderate to high risk of suicide, the safest course of action and the best treatment approach is to hospitalize the patient. And what you really do when you do that is you foist off potential responsibility onto the hospital, because if the hospital lets the patient go and the patient commits suicide, it's on them for the most part. David is making the case, which I agree with, that putting someone in the hospital, particularly when they don't agree, is not the best treatment option for the reasons that he's presented. My job is to explore what the risk management issues involved in making the decision not to hospitalize the patient. I'm not going to keep you in suspense. Obviously, this is a very complex question and will vary depending on the facts and circumstances of a specific case. And let me fast forward a little bit to say, if you are insured by the trust, if you have anybody that even mentions suicide, you call us. First of all, if you call us, we'll give you good advice, we think. But more importantly, we'll give you advice that you can put in your record, which will document that you are a careful and prudent provider who, in the first sign of trouble, called people who supposedly know what they're doing. In most situations, if one follows the risk management strategies, which I'm going to talk about, the risk of opting for this strategy, not hospitalizing, are manageable, and from a cost-benefit analysis, continuing to treat on an outpatient basis will lead to preferable clinical outcomes for many, if not most, of your clients. So let's talk a little bit about malpractice suits. Malpractice suits, the risk is really for outpatient psychologists. The risk of a malpractice suit is very low, somewhere beneath probably 1%, maybe depending on, we don't have really good data. The highest percentage that anybody suggested is 2%. Partly that's because bad cases, hard cases make bad law. And when you look at the actual cases for malpractice, what you see is there's a variable degree of responsibility assigned to people based on how much control they have over the patient. Outpatient providers, by and large, do not have very much control over the patients, and that's pretty much understood. So that if you show that you are an outpatient provider and you have tried to do the best you can, and we'll talk about how you try to do the best you can, your chances are very, very low. The real risk to psychologists, as I'll be talking about, is licensing board complaints. And this is where the gray area that David talks about comes in, because a high percentage of your population of treaters are people that at one point or another have thought about suicide. And that's often the reason they come to therapy in the first place. And putting them in the hospital makes absolutely no sense at all. And it creates all sorts of bad feeling on behalf of these people who don't think that they're suicidal. So if you're scared of somebody that presents with suicidal ideation, that's going to be communicated to the patient, and the patient is going to know, and it's going to be hard to establish a relationship where the patient is really willing to trust you enough to really deal with the situation directly. When I talk about good risk management, the first part of good risk management, which we'll talk about, is ninth grade algebra documentation. That substantially reduces risk, and I'll talk about what that is in a minute. 80% of defendants win if the case goes to trial. So that means if you are an outpatient psychologist and you're one of the 1% who gets sued at some point in a 20-year career, the chances are, if you go to trial, you're going to win. However, the bad news is that most cases settle, and the insurance company, by and large, has something to say about the settlement, because what they can say is, we'd like you to settle because we don't think you can win. And if you don't settle, you're going to be on your own for what we thought, anything above what we thought would be the exposure that we have. One of the good things about having the trust as your insurance is the board of the trust is actually a bunch of psychologists who can intervene in certain instances, although lots of times a provider who's lost a patient to suicide will want to take the case to the Supreme Court. And if everybody were allowed to dictate that the case could go to the Supreme Court, our premiums would be more like what psychiatrist premiums are, which is a lot higher than ours are. Next slide. So what is risk management? Risk management is the prospective assessment of retrospective evaluation. That is, when you're in a hard situation, you're thinking, okay, what if something goes wrong? How am I going to look if somebody comes after me as a result of that? Licensing boards in particular are looking to determine whether a psychologist is a prudent professional, aware of his or her professional and ethical responsibilities, who in a difficult situation carefully considered his or her options, where possible, consulted with colleagues, and then implemented a strategy designed to minimize harm. In other words, good risk management is the ability to demonstrate that you provided good, prudent professional care. Next slide. Documentation, documentation, documentation. Ninth grade algebra notes, you may remember ninth grade algebra notes. This is one of my favorites, and those of you that have seen me in workshops before have heard this over and over and over again, but it still bears repeating. So in ninth grade algebra, what the teacher said is, if you give me the answer and you're wrong, I can give you 0 or 100%. If you're right, I'll give you 100%. And if you're wrong, I'll give you 0. But if you showed your work and I can see where you went wrong, I can give you partial credit. So that's really true it's more true in risk management than it is in ninth grade algebra. So what ninth grade algebra notes consist of, and this, you don't have to do this for every session with every patient. This is a form that you go into when you think there's a high risk of a problem. What you did and why you did it, but almost more importantly, what you didn't do and why you didn't do it. And the reason that's more important is because if what you did and why you did it causes a real problem, then somebody's going to be thinking about, well, why didn't you do something else? And if you can show why you didn't do something else, that's very protective. And what advice you got and what you did with it also should be included. You need to do regular risk assessments, preferably with an empirically based instrument like David's talking about. I cannot tell you how important it is to have in your notes something that's been empirically validated. If you basically say, well, I have this instrument and it said that the risk is very low, and it turns out the risk is higher because somebody managed to beat the instrument or something has happened, that's going to do a lot more than even your ninth grade algebra notes, particularly if it's paired with ninth grade algebra notes. And then what David talked about is a formal plan to manage risk worked out with the patient and social supports if appropriate. And the difference, I remember people used to, when I started doing this, people talked about no suicide contracts, for which to patients were, well, you want me to sign this contract to protect you, not to protect me. And that's not a good basis to start therapy. whereas the, I can't remember what it's called, the RUD system, David, do you remember?
Safety planning or crisis response planning.
The crisis response plan. That's something that fits right in with a therapy relationship. You and the client transparently working together to work out a plan that you are included in so that you don't feel like you're foisting them off completely, but there are a number of steps that they go through before they would call you or would consider calling the suicide hotline, which would probably be one of the things that I would recommend that you put on that with certain kinds of cases. Next slide. The rest of risk management includes informed consent, usually as a contract, talking particularly about the limits to confidentiality. One of the things that your patients will want to know about, particularly adolescent patients or certain, what I like to call unemancipated adults, that is my children, who are perfectly willing to take your money, but insist that they are free to make their own bad decisions on a regular basis. What do you expect from the client about honesty and plan compliance? How do you work together to build the trust necessary so that when a patient is dysregulated, they will follow the plan and come back to you, and when they know that you're not going to hospitalize them at the first sign of danger, because it scares people to think about going to the hospital. They don't want to go to the hospital. And if they think that you're going to put them in the hospital, if they say certain things, they're not going to say those things. And that doesn't help anybody. Next slide. Consultation. Don't seek advice. Whoops. Want to go back? I lost the slide. And David's having trouble. I'm so glad somebody else has trouble with Zoom. There, next, no, you got it, and then it went back. So, consultation, I'll start before he gets the slide back.
I'm sorry, I just want to ask, did you want to say anything about medication or higher level of care?
You've already talked about medication and a higher level of care. Now, I suppose you might want to talk more about IOPs or...
we'll get to it later.
Okay, that's what I thought. Consultation. Don't seek advice if you're not willing to seriously consider it. Use the trust, as I've already said. It's very good to put the advice that you're getting, even if there's disagreement, because in many of these cases, there will be disagreement between you and other colleagues, and maybe disagreement between you and the trust. The best kinds of consultations say, on the one hand, here's the potential benefits, here's the potential risks. On the other hand, here's the potential risks, and here's the potential benefits. You have to decide, and it's not, nobody's gonna say, if you do this, 100% it's gonna work, and if you don't do it, it's 0% that you're gonna have a good result. Preparation. It's really important to think about what you're gonna do with suicidal clients. Now, I'm gonna recommend, as David's gonna recommend, that if you're not DBT trained, because DBT is another effective mechanism for dealing with this. You use CAMS, which is a form, I think, of probably of cognitive behavioral therapy that's specifically geared to potential suicide. And dealing with your countertransference is really important. If you don't think you can work with suicidal patients, try hard not to do it. Next slide. Now, this is the hardest thing we get. We get lots of calls, not lots of calls, but enough calls so that every one of our risk managers is familiar with what happens when you lose a patient. Losing a patient to suicide is the most traumatic thing that can happen in your professional career, because no matter how rationally you believe you did everything you could, you're a psychologist, your job is to help people. When one of your patients dies, it's very hard to argue with yourself that you aren't somehow responsible, even though you're really not. The most important thing, in my judgment, is to be a human being. If somebody's parent calls you and they've lost a patient to suicide and they want to talk to you, don't say you have to prove to me that you're the legal representative when you know, in fact, that's the case they're going to be able to make. Managing your own trauma and grief. Every time anybody loses a patient to suicide and they call us, we say you need to get a brief stint of therapy. Because if you don't grieve this loss, it's hard because it's not really a member of your family, but in some ways, many of your clients are closer to you in relationship than members of your family. Certainly than your Uncle Louis in Cleveland. So not only that, if you all know this, of course, if you don't manage your own trauma and grieve it, then it'll come and bite you in the ass the next time you have a similar situation. Dealing with survivors, that's a case-by-case method, but the more human you can be in dealing with them, the better the outcome will be. There was an old theory of risk management in hospitals, which was if a bad thing happens, you shut down everybody. You don't apologize, you don't admit everything, you don't talk to people, you send it to the lawyers. There is now good evidence that shows that apologies will reduce the amount of malpractice suits, will reduce the amount of money that's agreed to as part of a settlement, all those kinds of things. And that's really been true in the feedback we get from people who have lost a patient. What about the funeral? Go to the funeral. There are some situations where that won't be appropriate, where people are really mad at you. If you go though, and somebody asks you why you're there, you say, I came to pay my respects to this individual. I think he deserves my respect. You don't say, well, I was his therapist and this is what Eric Harris told me to do. Next slide. Oh, that's it. Okay, I'm done.
Well, not completely, but we'll come back to.
I know you'll come back to me, I'm sure.
Yep. So, so that sets up a dive here on the evidence base and what actually works. Thank you, Eric. One of the things that I think is sort of axiomatic in my way of thinking is that if you do things that are proven to work, you're going to decrease your liability. And so I'm obviously a fan of evidence-based interventions. And for a lot of psychologists, they don't necessarily know that the psychological interventions are the most effective by far. I think about this in terms of the American Psychologist that we all get. There have been special issues on virtually every topic under the sun that I can think of in the American Psychologist, never one on suicide. Isn't that interesting? It's just something that we just don't grapple with, even though psychologists are leading the pack in terms of what works. So this is a paper we published a few years ago on the randomized controlled trials, which we know from the pandemic and the vaccines is the way that we prove something works in a causal manner. Is same with psychotherapies and interventions. And we know that there are about 90 plus RCTs for the treatment of ideation and behavior, suicidal behavior. It's a tough study to do. We don't know that inpatient care is effective. We do know there's increased post-discharge risk. There's a study that was published at the University of Michigan, Cheryl King's group for teenagers, showing that a second hospitalization for a teenager was significantly correlated with a much more severe trajectory and increased suicide attempts. So again, it's correlational. You can't say it's causal, but we've got to think about what's happening in those inpatient stays. They could be improved, and some are excellent. So I don't mean to totally wipe out that there's no good inpatient care. I've spent too many years working in inpatient care to completely dismiss it. But in my view, it's not suicide specific enough, and it could be improved. There's a handful of treatments, mentalization-based therapy by Bateman and Fonagy. There's an intervention called ASIP developed by Conrad Michel and Anya Millard that have a single randomized control trial. So that's good. And I'd recommend those interventions quite highly. But if we want to get to the highest level, we're talking about randomized control trials with replicated findings with independent labs finding the same findings. And so that list is relatively short. And that consists of DBT, 2 forms of suicide-specific cognitive therapy, CAMS, which we're going to talk about, and something called non-demand caring contact. So hopefully a number of you are familiar with DBT. DBT is by far the most evidence-based proven intervention. It's pretty labor-intensive. It's a team treatment. It's got its 4 components, which is skills group, individual psychotherapy that supports the skill building, out-of-session phone coaching, and then consultation of the treatment team. Marsha Linehan was a research mentor of mine. She's now retired, but her contribution to our field has been profound, to say the least. Krista Koo and the team at University of Washington did a meta-analysis of 18 RCTs of DBT and clearly showed it's effective in reducing self-harm behavior and attempt behaviors. It's by far the most effective treatment. There's also reductions in crisis services. Interestingly, there's not reliable reductions in suicidal ideation. Now, in fairness, this might be because the DBT focus is on behavior and not necessarily on ideation as a dependent variable. There's a couple of studies with a reduction in ideation, but where there's no question that DBT reduces self-harm, cutting behavior, self-harm behavior, and suicide attempts better than any other treatment of all. It's labor intensive and hard to learn. Then there are two forms of cognitive therapy. CTSP, developed by Aaron Beck and Greg Brown at the University of Pennsylvania. Greg was the lead author on a paper published in the Journal of American Medical Association, where they looked at different kinds of thoughts and images and core beliefs in what Tim Beck refers to as the suicidal mode. This modal model is consistent with Dr. Beck's sort of cognitive therapy approach to things. The suicidal mode is unique and special, and how you adapt when the mode is activated and how you prevent relapse is central to this intervention. 10 sessions in total in the JAMA paper that was published in 2005. Results of the study, a 50% reduction in attempt behaviors, which is awesome. Fantastic outcome, reducing suicide attempt behaviors by half. That's how you get published in JAMA. And also lower scores on the BDI. But again, not necessarily lower scores on ideation, which is to the point I made earlier. And significantly lower levels of hopelessness. Hopelessness is probably a major mechanism in effective care, and I'll speak to that a little bit more as we go. David Rudd and Craig Bryan published a paper that was conducted at Fort Carson in Colorado with infantry soldiers who have been heavily deployed to Afghanistan and Iraq. This is BCBT, or brief cognitive behavioral therapy. It's a phasic treatment with four different phases. A cousin of sorts of CTSP. David trained with Dr. Beck's group. He and Craig are cognitive therapists, and they clearly have an effective treatment that reduced attempt behaviors by 60%. So they even bested the CTSP study that Greg and Tim did at Penn. And this is a 2-year follow-up, which is fantastic data to get. Soldiers were less likely to be medically retired than soldiers in treatment. This is retention to care, or actually in this case, retention to the military, which is a big consideration for the military, obviously. Now, before I move on to CAMS, here's the two downsides to these 2 or 3 different treatments I've described. One is that to do DBT, you had to be a behavior therapist. So if you're psychodynamically trained or you think of things more cognitively, you really have to lock in on behavior therapy to do DBT adherently. Same for CTSP and BCBT. You have to be a cognitive therapist to really do these treatments. They're built on principles of behaviorism, radical behaviorism in Marcia's case, and this using the suicidal mode. So that's okay for many of you. I'm not being critical in any way. But also another challenge is you can get trained in DBT, but it's a very labor-intensive task. It's a team treatment where you spend a week of training, basically 8 to 9 hour days in training, and then 6 months later, another week of training to do DBT adherently. So it's a very labor-intensive intervention. Fantastic data, amazing outcomes, well studied. But the trick here, or the catch is, when Marcia developed DBT, she realized she couldn't train the entire world in how to use DBT. So she founded behavior technology, which is a business, which for treatment researchers is really sort of like the dark side, because making money and doing science are seen as sort of like incompatible. But that's how DBT became world famous. And there are now other training companies that train in DBT. Right now, except for a couple of trainings that the Beck Institute hosts with Marjan Holloway from Uniform Services, there isn't reliable training in CTSP or BCBT, unless you can get Craig Bryan, who's very busy, or Greg Brown, and sort of capture their attention. It's a pretty labor-intensive treatment to learn as well. I think last I checked, 16 hours of didactics and many dozens of hours of supervised practice to really master the intervention. So I'm not saying this to ding these interventions. The data speak for themselves. But one of the challenges about doing effective care is actually having access to it, the training. And so that's one of the things that we try to remedy in the CAMS approach. So let's talk a little bit about CAMS, the Collaborative Assessment and Management of Suicidality, which you may have never heard of, and that's fine. Camscare is the training company that trains and consults in the intervention. It incorporates a risk assessment, tracking, and treatment framework, so it's not a new psychotherapy. We take all comers. You can be behavior therapist, you can be psychoanalyst. We don't really care what your theoretical orientation is. We think it actually really helps with malpractice considerations. It's designed to keep a suicidal person out of the hospital, if at all possible, unless it's being used in an inpatient setting, which it has been used and is increasingly being used as an inpatient intervention in that kind of treatment setting. But typically, we're trying to keep somebody out of the hospital. It's the best treatment by far for reducing suicidal ideation. Again, the biggest population in the suicide challenge. It focuses on suicide as the presenting problem. Like CTSP, BCBT, and DBT, we don't care about the diagnosis. We care about the suicidal thoughts and behaviors. The evidence indicates that CAMS is probably best for newer suicidal people and may be less effective, but not ineffective for more chronic states. That data is still pending. And patients like CAMS patients like it, and they like not being hospitalized, as we've talked about. And there's evidence that there's cost reductions as well associated with use of CAMS. We have a paper under review right now about CAMS being used in a military installation that was significantly more cost effective than usual care. So as mentioned by the previous editorial, CAMS really locks in on ideation, and we have replicated now across multiple RCTs, a quick rapid reduction in ideation in about 6 to 8 sessions. The framework is really built on the idea that we understand what makes a person want to kill themselves, which we call drivers. So something that's very unique to CAMS is that we ask the suicidal patient, what do you want to kill yourself about? And they'll say things like, my wife is leaving me. I can't get a job. My mother just died of COVID-19. I hate myself. I'm ugly. People say things like this who are suicidal. And with some variation, we can treat a lot of those problems with things that you've gone to a lot of school to learn about. So we think of direct drivers and indirect drivers. We have a model of thinking about what are the issues or problems that put this patient in peril, and we target and treat those in CAMS. The assessment is a way to support the patient. We know from meta-analysis that it is a therapeutic assessment. We know that the stabilization plan, which is our version of safety planning, is a resource to the patients that can help them get through a suicidal dark moment. The treatment treats direct drivers and indirect drivers, and the framework provides a roadmap to think about treating the drivers of suicidal ideation. So in summary, these are the data. We drop ideation like a rock overall, symptom distress and depression. We decrease hopelessness, increase hope, and change how suicidal people think about suicide. Retention to care is better in CAMS, and these are across RCTs, 5 published RCTs, 1 meta-analysis, 8 published correlational trials. There's correlational and RCT data that we can decrease ED visits in certain subgroups. And there's trending data that CAMS can be effective on par with DBT in one study in Copenhagen, Denmark, for self-harm and suicide attempts, but the study was underpowered, so it was a non-significant finding. And one big virtue is that it's relatively easy to learn. It has adaptations, and that's good because with adaptations, we can think about a flexibility model, which is desirable, to be sure. CAMS was originally developed in a university counseling center, my university, in fact. There's now a randomized controlled trial called the Campus Study. I can't remember the acronym, but it's a smart design where 700 students from 4 universities will be randomly assigned to CAMS versus treatment as usual for 8 weeks. second random assignment will be to 16 weeks of CAMS or 16 weeks of dialectical behavior therapy. So we know from our preliminary research that about half of that sample is going to respond in the 6 or 8 sessions to both CAMS and treatment as usual. CAMS was significantly superior in decreasing ideation and depression than treatment as usual. CAMS was less effective with multiple attempters who were highly dysregulated and had features of borderline personality disorder. In that arm of the trial, they actually did better in treatment as usual. And I'm thinking that's the sweet spot for dialectical behavior therapy. Highly dysregulated, multiple attempters with a chronic suicidal history with borderline personality disorder or features. So in the big trial, the $11 million multi-site, we're going to have 700 students across 4 universities fully populate the SMART design. COVID hit. We weren't able to start the trial in September as we had planned. NIMH authorized us to flip it to a feasibility trial to study what? The feasibility of online training, like you're getting right now. Is that an effective way of delivering training? We think it is at Camscare. But is it for DBT? Because that's a rather new development and pandemically driven. Can we deliver these treatments on telehealth? And so back in March, Camscare moved swiftly to develop a response to the COVID-19 pandemic, realizing that all of us were being pushed into telehealth probably way earlier than we thought we might be. And what we found was we can manage this in a Zoom-related or other secure platform, DoxyMe, there are others, and do telehealth work even with suicidal patients. Now, what's interesting about this, I'll be curious about Eric's thoughts on this, is that a lot of the trade associations were saying when they were giving out guidelines for telehealth, you could see suicidal patients, but it's very high risk. And because they're remotely located, an emergency situation might be more difficult to manage. And that's become a big issue. And I call it the tackle factor. That apparently, if you can't tackle a patient who's running out of your office who's suicidal, you can't effectively treat them. And I would argue that's not the case. But we know from actually a task force that I'm in for the Suicide Prevention Resource Center, that large healthcare systems, with the advent of the pandemic, were now suddenly suspending asking about suicide risk, suspending screening for suicide risk, because it's being done on telehealth. So clinicians were then flying without knowing whether the patients they're seeing in telehealth are actually suicidal, because apparently we can't do this work remotely. I've, since March, been on a number of webinars saying, yes, you can do this remotely. You just have to do the very things that Dr. Harris described. You have to use informed consent. You have to be very clear that there may be third parties that we need to contact in case of an emergency. And then there's always this challenge that we have right now, especially, and I want to say this with very sensitive deference, that sending the police to do a wellness check, a person with a gun, and if you're a person of color, that might be not a great scenario for you. And a lot of police officers don't have specific training in mental health crises. And then they're going to take you to the emergency department that's packed with COVID-19 patients. So we'll get into this, I'm sure, because the pandemic has turned our professional lives upside down. But we would contend that there's a way that you can do this effectively online. You just have to be very thoughtful about these risk management aspects. And the alternative to wait till we flatten the curve and not see suicidal people is just not acceptable, in my view. We can't morally justify that. So we just got to make some adaptations, and again, be mindful of the directions and the guidance that that has been provided by Eric in terms of informed consent, being transparent about how we do things, how we have policies around emergencies. Eric, you want to chime in?
Yeah, I want to talk about telehealth. When we started setting up telehealth APA many years before, we thought it would be 20 years, 15 years before people would really have adapted telehealth. And one of the myths that we discovered right away was that somehow being in the room with somebody was superior to actually working with them online. And all the research shows that that's not true.
Right.
And I think that the fact that people say you can't screen is part of that same old malpractice thing. Is if you can't put somebody in the hospital, you shouldn't be working with them remotely, because somehow seeing them in person makes a difference. Now, the problem is if you're doing remote teletherapy in a different state, say because of the emergency, that becomes a little more difficult. You don't know how to handle an emergency, and you want to, but it can be done if you have an emergency plan that and there's support, a social support system that's willing to help you with it, and et cetera.
Yeah, I appreciate the comment. And I think what the literature shows is that retention to care is better. You have fewer dropouts and fewer no-shows in a telehealth modality. And what I can say, at least in the CAM side of it, when we flip to telehealth, and we've done this in 3 clinical trials, the patients like it. They like not being seen walking into the counseling center. They like being able to talk to their therapist with their cat on their lap. And clinicians are surprised how much they like it. So I'm sure we'll talk more about telehealth, and it's a very important topic, and I'm digressing a bit from adaptations here, but I don't need to belabor this. The most extensive research that we've done is using CAMs in community mental health agencies in the US and abroad, in Norway, in Copenhagen, across Denmark, actually. We've seen it's used in military facilities. We've seen it used in VA. We're trying to get funded to do an RCT of CAMS groups, which is a very cost-effective way of working with veterans who are suicidal. We've seen wide use across the state of Oklahoma. That's engaged us in training outpatient care, also respite care, and inpatient settings. I've done training, and Camscare has done training with Native American populations, where Western medicine doesn't have to be imposed on the culture. Native ritual or native medicines can be used to treat suicidal drivers. So we don't dictate in CAMS how to do treatment. And a lot of providers like that. So it's got a cultural sensitivity because it's so patient-centric that I think is rather unique and flexible, frankly. We've seen it used extensively in the California penal system, in the Georgia juvenile justice system. We're adapting it now for teenagers, even to children. And it looks like two clinical trials are going to be funded by the NIMH for suicidal teens. You've seen it used in EAPs, more on the assessment side of things, and absolutely used in clinical private practices, which is a special focus for us here this evening. Just kind of want to round the turn here and talk about caring contact. This is a whole literature, I'm not going to really delve into it, where after a very brief contact or discharge from a hospital or ED, a caring letter or postcard or a phone call is made. Emails and texts, different modalities have been made to say, how you doing? We haven't forgotten about you. Something that simple has been shown in multiple clinical trials, randomized controlled trials, to decrease completion behaviors along with attempts. So if you're working in a system of care, having some kind of caring contact follow-up has a robust evidence base and is a good thing to do. And it's just a nice thing to do to not feel forgotten. Maddie Gould has a model where people being discharged from the emergency department might engage the local crisis center to have crisis center workers make follow-up phone calls. And patients really like being followed up with. So it's a thoughtful thing to do. It's probably good practice as well. These are a couple of websites of people with lived experience who are people who've been suicidal or make suicide attempts and are pretty critical, frankly, of us and don't like a lot of what has been conventional mental health care, from medication to hospitalizations to the use of ECT to being committed against one's will. People with lived experience are very vocal that they want a different kind of model. And these individuals are Ursa Weisside, who's a clinical psychologist, Desiree Stage, who's a lived experience expert, DeQuincy Lazine, who's another psychologist, have websites that you can actually send your clients to for support and for self-help, which I think is a great addition to our toolkit. Postvention is the tragedy of a suicide occurring, and none of us are immune. I had a patient that I tested in the VA when I was an intern. I spent 2 hours with him testing, and 2 weeks later, he laid down in front of a bus and was crushed. I've had 6 really close calls of patients making attempts. We've lost 4 patients in randomized controlled trials. So I've been haunted by the deaths and loss of patients, and it does come with the territory. What I want to say is the thing that makes me so excited to be on this webinar with Dr. Harris is that his response to a completed suicide is to be a human. That is the best possible advice that I think he could give. I'm mindful of Marsha Linehan talking about in public forums suicides that occurred in DBT, where the lawyers at University of Washington were saying, circle the wagons, don't talk to the family, hide, batten the hatches. And Marsha had a protocol where they would send flowers, they would send cards, they'd invite the family to the lab, and they would always go to the funeral. And they never once got sued in all the years that Marsha was studying DBT at the University of Washington. So, there's a right way to handle this. And I think being human is the place to start. I have consulted with Dr. Harris on more than one occasion. I pay my trust insurance premiums, and I know that talking to him is one of the best things I can do, both for good advice and also to document the fact that I sought consultation with the trust. So you really do want to use consultation liberally, and you do want to document that consultation and really loop in the people that can make a difference. A lot of times postvention involves a psychological autopsy or a retrospective analysis about what happened to kind of figure out what can we do differently. If you're an individual in private practice and you lose someone to suicide, it is wretched. And what I can do is route you to the American Association of Suicidology for the Clinician Survivor Task Force and the resources on the AAS listserv for clinicians who've lost somebody. There's at least a literature and people in the organization who can provide consultation and direct you to the right resources. Eric.
I just want to say something about doing a post-mortem. If an insurance company approaches you saying, we want to do a post-mortem, you need to make sure that that is covered by the state peer review law. Because if it's not, anything you say can and will be used against you. So you need to be really careful, and you can say no to them. They aren't going to beat you about the head or drop you from the insurance plan. You need to say, I'm perfectly happy to cooperate as long as you can assure me in writing that this is covered by the state's peer review law, and therefore it can't be used in a lawsuit.
Yeah, there's some nuances and some tricky challenges that are oftentimes jurisdictionally defined. If you're a supervisor and your trainee loses a patient, there are some kinds of tricky considerations around your liability in that situation and who you can talk to about what. Do aggressive plan fraternities write stern letters demanding your records, even though they're not a judge and don't have subpoena power? All the time. Do you have a right to ignore those letters? Yes, you do. If a judge sends you a subpoena, that's another matter, right?
Another thing you call the trust immediately is if you get a subpoena or somebody says you have to go to court. And believe me, I don't have to tell the people who are insured by the trust to do that because they do all the time. The thing is, anytime you get what we have with psychologists, I think, and probably all mental health professionals, certainly non-psychiatrists, is what I call post-traumatic, pre-traumatic stress disorder of legal involvement. That psychologists are irrationally scared of what the situation is when they're dealing with cases. And usually the advice we give, which is most helpful to them in that situation, is you're not Hamlet in this particular drama. You may feel like you're Hamlet, but actually you're the Banquo's ghost. You got one good scene and heard from no more. But knowing about suicide, knowing about subpoenas is also state specific. So California has this weird law and Virginia has a weird law. So it's a good idea to call and get some advice if you get a subpoena. You don't have to hire your own lawyer though, in most cases. And if you're insured by the trust and you get a subpoena and it's not a forensic case, you would be able to get legal counsel at our expense by virtue of your policy. So I just wanted to add all those things.
That's really valuable. What I would do just to add on to that is if you get a subpoena to produce your records, I would never do that without talking to a lawyer. I would always want to rely on legal counsel because there are recourses from even a judge's subpoena, if I'm right, Eric, that it can be potentially quashed and or a third party can be assigned to review the records if you deem that the release of those records could somehow harm the person that's being that's represented in those records.
Yeah, that's right. I don't know that you have to talk to a lawyer. All you have to do is talk to a trust risk management consultant.
Well, there's that. So that's where a lawyer is actually your friend and on your side to help give you advice. Okay, so this is maybe a challenging thought for some of you, but the idea that you could actually develop mastery in this content area. There's a lot of suicidal people. We've told you there are millions of people with suicidal thoughts, and you could become competent in this intervention or with these interventions and actually get in life-saving business and get business because there's a lot of providers who refuse to see suicidal clients, especially in prior practice. So that may be a bridge too far for some of you, but I want to sort of challenge you to think that maybe this is something you can develop a specialized area of expertise. Eric?
Yeah, I want to agree with this. One of the problems that we have with David is he's very humble, at least in this particular area. And we had to argue about whether or not he could promote CAMS because he doesn't want to be a whatever you do. He's not selling snake oil is what I want to say. Yeah. This is I was the one I think originally suggested that you have a list of CAMS certified people, right?
Yeah, we do.
And so if you get the training and you become CAMS certified, you can actually promote that. And there's lots of people will even tell people who call us that that's one particular option. If they really don't want to see, some therapists just do not want to have anything to do with suicide, and they shouldn't if they feel that strongly, as they're not going to be helping.
Yeah, I appreciate that. I really try to sort of follow the science and I've described all the effective approaches. But CAMS obviously is my favorite, and I appreciate Eric saying that. There is, I'm going to get into a CAMS trained designation, and we're moving towards certification if you want to develop some competency in this. So let me just sort of propose this as a metaphor that you could do CAMS. And all this is kind of built in, all these elements that Eric and I have been talking about. Or you could do other practices that sort of touch on the same points. And obviously, one way is, in my view, easier than the other. But as Eric was saying, the alliance is the key. And the nature of suicide risk is to pit us against the client. Have you thought about suicide? Yes, I have. Well, you can't kill yourself. The law says, who the hell are you? It's my life. I can do what I want. No, you can't. Yes, I can. I'm calling the police. Go ahead. Everything about that exchange is counter-therapeutic. So it's not a trick, but in non-pandemic times, we ask permission to take a seat next to the patient because we're trying to get on the same team. We're trying to get out of an adversarial relationship and into an alliance. And we're trying to increase the patient's motivation to want to be a part of their own treatment. So part of how we do that is through something called the suicide status form, which we think of as the roadmap that guides the assessment and treatment planning for a suicide-focused intervention. For those of you that are interested in this, you can buy the Guilford Press book, 2016, second edition, and get access to these forms. Or you can go to the Camscare website, and I know that we've made that information available to you by virtue of this webinar, and we can get the SSF to you and train you in its use. Camscare provides training in a menued kind of way. There are people that can read the book. You can get 6 CE credits for it, copy the forms, and use it with the patient the next day. Other people need a little bit more. There's an online training. All the training is online. But in any case, we use the SSF, the suicide status form, to assess certain key quantitative and qualitative variables with robust psychometrics on the core assessment that's administered in every session. So it's valid and reliable with college students and with inpatients at the Mayo Clinic and with suicidal teenagers in Kentucky. So we know the psychometrics of the core assessment are strong. We also know that the qualitative responses are really valuable in telling us really important things as the patient unpacks what it means for them to be suicidal. We emphasize empathy and collaboration, and we're suicide focused, and we're always honest. We're always clear about the law and what the law as a mandated reporter and as a licensed professional, what I have to do if you're in imminent danger. But we use that as a pivot point to try to find a way to work through your risk and warning signs to create an outpatient treatment plan. What's not negotiable is the stabilization plan. So this is our variation of the safety plan, reducing access to lethal means, different kinds of problem-solving strategies, decreasing your isolation, and potential barriers to care. And then right here, what are the two problems that make you want to kill yourself? And we have many treatments that we know can treat these problems. And in that exchange, there invariably is a flicker of hope. You know how to treat these problems? You know how to treat my trauma history? You know how to treat combat-related PTSD? Yeah, we know how to treat these things. We can treat the problems that make you think that suicide is your only option. And then to make the lawyers happy, Eric, we have an additional page of documentation that we lovingly refer to as the HIPAA page. A mental status exam of an ICD or DSM diagnosis or overall judgment of risk in your case notes. So the SSF can be the medical record progress note. It can function as a complete medical record progress note. There are interim versions of the SSF where we start out with the core assessment and we always end with the treatment plan update. What are we treating? The problems that the patient says make them want to kill themselves. What are we crafting? The stabilization plan. We have criteria or different outcomes that are handled by the outcome disposition version of the SSF. So it's a really complete roadmap, and most of your documentation is being conducted in session with the patient, and the patient gets a copy of their SSF, or they take pictures of it on their phone, because we want them to refer to this as they get better. We want them to keep a file folder of all of their SSFs to watch their progress as the treatment of their drivers is effective over care. This is a SSF from a graduate student case, just to kind of make this real. This is a person, we have electronic version of the SSF through Microsoft Office group in Redmond, Washington on a Surface. So we can replicate all this and flip it into alphanumeric language and send it off to the EMR on a Microsoft Surface. We have a fillable PDF version of this since the pandemic. But one of the things I kind of love about the hard copy is patients make up their own scales. So on the hopelessness scale here, she gives herself a 10. On the life in general scale, she gives herself a 5. Very existential flavor, a very detailed discussion about getting access to a gun. Multiple attempt history, and she was previously hospitalized. Now, this is a really skilled CAMS clinician, and he's trained with me on more than one occasion and done superb work in his training site as well. And the tragedy here is that this woman took her life. And I did a consult in the case. And the true story is that he did all the right things and saw the patient, and the documentation was clear. 6 months later, her parents came across a file folder full of SSFs, which included his number, and they called him. And he talked to the mother and then the father for 2 hours. Of course, his heart fell out of his chest. He was terrified to speak to them. But at the end of the conversation, the parents said, "And what can we do for you?" Because at least we have the comfort of knowing that our daughter's clinician didn't have his head in the sand on this topic, and you must be grieving too. In this file folder was a receipt of a gun that she bought a week or 2 prior to her first appointment with this clinician. And the mother said, we think she didn't reveal this to you when you asked her right here because she didn't want to be hospitalized. And the clinician said, well, I would have tried not to hospitalize her with this intervention. The mother said, can we keep in touch with you? Because we really appreciate what you tried to do for our daughter. That's a very different scenario than somebody showing up with a subpoena, demanding your records out for blood. It's a very different scenario. And the documentation here made a big difference. We had a case at a local counseling center of a young man that was seen in CAMS for 20 sessions, shot himself, had dropped out of treatment. The clinician tried 4 separate times to get him back into care, and he wouldn't come back, and he shot himself. Mother came down from New York City with a high-powered plaintiff's attorney demanding to burn this institution to the ground with litigation. The counseling center director just gave them the file. And the lawyer flipped through the file and looked at the SSFs and said, we don't have a case. She hired 2 more attorneys who came to the same conclusion. These aren't warm, fuzzy stories. And I'm aware of a handful of cases of completed suicides that were engaged in CAMs, but there's no negligence if you're doing it adherently and the documentation is clear. And we don't drop the ball and it's suicide focused. I can't end on those cases. This is a case of a 9/11 dropout, high school dropout, who joined the Marine Corps. He was hospitalized at the Denver VA for 6 months. The staff loved this man, and they were terrified of discharging him because they were afraid he's going to walk out and step in front of a car and be killed. So I was brought in the case to consult, and they started CAMS for 2 sessions while I was still in the inpatient unit right before discharge, and he was seen for another 10 sessions. And it all came together for this man. And one of the most extraordinary moments in my professional career was that the clinician, the social worker that was the CAMS clinician here, bought this man a paint kit because he was a painter in high school. And as a Marine, he dropped painting. And she got him back to painting. And I happened to be walking into the hospital to meet with the research group when I saw the entire treatment team walking towards me, going to a small exhibition at a local library of this patient's paintings, and then going out to dinner afterwards to celebrate the success of this case. So they don't all go this way. Some are tragedies, but there's a way you can ensure that you're following the best practices here in an evidence base that's robust. So clearly, evidence-based, it's affordable. It's a menued approach to training. We treat the largest population, which are the ideators. It's cost-effective. It's easy to learn and easy to implement. In our clinical trials, clinicians are using CAMS adherently with their first patient in 4 sessions. So it's pretty easy to pick up. And you have this enhanced documentation that Eric and I have been going on about in this presentation. We're just about to transition here to our Q&A, and I'm just about wrapping up the last of my slides. This is something now offered at Camscare at our website for people who are sufficiently trained. You get the CAMS trained designation. There are these arrangements that we're making with the trust, the National Register, where we're creating discounts and incentives. We really are incentivizing students to get training in this evidence-based approach. It's not the only approach, but it is readily available and you can get the training online. We're moving towards a certification model, but we're offering this now and being put on the clinician locator.
David, is this, do you get CEs with this too?
With all this, you get CEs. So there's a 3-hour course that you get CEs. You get 6 hours for CEs on the book. Mm-hmm. You get a day of CEs for role play training that we do on Zoom, putting people in breakout rooms. And then we don't get CEs for consultation calls, but the consultation calls are also really valuable. So with that, we are at our question and answer stage. I'm trying to remember how we're going to do this.
Jen is going to send you some.
Oh, yeah. Oh, I've got a slew of them here.
While he's looking, I just want to let you all know that there's 1,700 of you, and there's about 100 questions. So obviously, we're not going to get to all of them.
I'm going to actually just stop sharing so you can see our beautiful faces because there's nothing to see. Okay. Suicide rates related to COVID. Obviously, we don't know yet. We know that ideation's up. We know that ideation's up with young people and ideation's up with people of color. People who are caretaking, people who have COVID-19 are significantly at risk. So that certainly is something that we're haunted by.
And David, do you think that there'll be an uptick after the pandemic is over when people have managed the stress and then go back to their real lives?
I really don't know. I mean, the sociologists would say social isolation is endemic of increased suicide. So Emil Durkheim had a whole sociological theory, an increasing risk based on social integration or social isolation. I'm in the camp that thought there was going to be a repression of sorts because people would, just like 9/11, people rose up and we came together for once as a country. Not at all true now, obviously. But we rose to the occasion, and suicide rates went down. Suicide rates have typically gone down in time of war until the last more recent wars, where we started out with a lower rate, and then in 2008 just went through the moon and actually eclipsed civilian rates. So we don't know, but I do feel concerned about the increased ideation. We'll see in 2 years. Love to hear thoughts about regarding what to do if patient commits suicide. I think we've handled this. Attend the funeral, handle records. Any other further thoughts on that, Eric?
No, I think the best thing is deal with your own grief first. And if you're going to meet with them soon after the suicide, get some consultation just to make sure you have dealt with enough of your feelings. Again, you lose nothing by being a human being, because people think, well, I'm going to talk to the mother, and what she's going to be doing is gathering evidence to use to the malpractice lawyer. And that's never happened in my experience, which now goes back 25 years. So I don't think there's anything to lose. And I'll tell you, the other thing is, being a human being is so much better for your own psychological well-being. Having to be phony or be protective of yourself and worry about, well, I can't really talk because it's going to get me in trouble.
I think about my brother, who had a history of cancer and treatments that were, saved his life for many years, but where over the years that the treatments became part of the problem. He was having cardiac issues, and we met with the surgeon who said, basically about 12% chance of doing this extremely high risk procedure on your brother. And I'd be well within my practice, sort of parameters to refuse the case. And we begged him, to take the risk. And he said, well, you're nice people. And, your brother seems like a really great guy. We'll go for it. When he died post-operatively, it never occurred to us to sue him for malpractice. It didn't even cross our minds. In fact, my sister-in-law went to the surgeon, got an appointment with him to sit down with him to thank him for taking the risk. So my view is, suicide is ubiquitous enough that, if you went to a primary care doctor and said, oh yeah, I'll give you a full physical, I just don't check out the heart issues. That's outside of my comfort zone. You'd think he or she was crazy. Suicide is pervasive enough that we can't sort of say, oh, I'm not trained in this. In my view, you can get trained in this. You don't have to be an expert. You don't have to become a clinical suicidologist, but you can get competent enough, even by the stuff we're describing here, to help save lives. So in my mind, we should do that and not avoid these patients, because, in other fields, clinicians lose patients in a variety of ways. This is the single way that we lose patients. So, let me ask you this, Eric. If I have a middle-aged white male gun owner with major depression, alcoholic, who's made 2 or 3 previous suicide attempts, has a horrible history of compliance with care and insomnia, could I...
Agitation?
And agitated, of course. Could I have a conversation with him where I would make conditional working with him to meet with his family?
Yeah, I would probably recommend that.
Right.
And part of what we're talking about in terms of hospitalization is if you've got a support system and you've been able to access it, that's a much safer way not to hospitalize, because you'll be able to talk to the people that could sue you and explain to them why you're doing what you're doing. Now, some clients won't buy that, and of course.
Could you make it conditional on proceeding with them?
Yes. Well,
a lot of providers don't think you can do that.
That's too simple. In certain instances, you could. I think it really depends on what kind of relationship you've had. It's hard to say yes or no to that. But I would say that if you're willing to take the risk, you can.
I would say, just like the surgeon, you could sit down with the family, or you could sit down with the patient and say, I'm willing to work with you, but I would need to meet with your support system to talk about the risks and what I can and can't do.
Right. That you could if he's just coming to you for treatment, but what if it's in the middle?
That's different, isn't it?
Yeah.
But in the model that I use in my practice, I have a single consultation session with no strings attached about whether I'm going to proceed with them or not.
Yeah, that's a good strategy, and in that situation, yes, if somebody's coming to you new, unless they're, if you think they're imminently suicidal, and if you let them leave your room, they're going to kill themselves.
Right.
It's of course it's really hard to make generalizations. My experience, there's so much factual differences between cases, but basically the answer to your question is yes, and I've recommended it on several occasions when people have called me.
How often, Eric, do you think we should be asking about suicidal risk and homicidal risk in the course of routine practice?
Well, you should be talking about it. You should always ask on the first session.
Yep.
And depending on the answer you get, it depends on how much you ask it in the future. If a patient has suicidal ideation, then I think you're going to regularly check in about, that, because partly what you're saying, and I think it's right, is that the suicidal ideation is the thing you need to treat. So if you don't ask, they won't tell.
So here's a question for me, but I'd love your comment on it. What do you do when they're saying they're suicidal, but they don't want to focus on it? Where with CAMS, that's all you focus on until it goes away.
Well, I think if you're a CAMS trained person and that's what you do, you basically refer them elsewhere. I think, because you can't force them to do what, Right. I think there's a lot of people that wouldn't be comfortable. There's particularly people who have their own ideas of what therapy is, and want it to be a warm and fuzzy relationship and not talk about suicide. I think that's irresponsible to do that. But when my sense of it is people out there, you're going to have a gut feeling about, and particularly what I like most about this is that there's a scale you can use that I think clinical judgment about, for people that aren't really trained and haven't had much experience with suicide, is more likely to not be accurate for all sorts of countertransferential reasons. So that if you have a scale that you use, then the scale should tell you how often you have to ask.
One of the things we see, my response is sort of like, what's more important than your life or death? What else would we treat? And if we treat this effectively, we'll move it off the table so we can talk about other things. And typically the things you want to kill yourself are the things we should treat anyway. So I think it's sort of in my view, sort of a bias. It's kind of a false notion that you're going to have this sort of split. And then you had the situation I had, like I described, where I had this very complex case of a guy that was ongoing care. I did CAMS on Tuesday and everything else on Friday.
Right. That's a good, I like that approach quite a lot.
My patients have terminal illnesses. Some say they do not want to get totally helpless and choose to leave before that. I don't know what to say to them.
You can say to them that, in my judgment, what you should say to them is, I'm happy to have you talk about it. I'm not going to take a position one way or the other on what you're going to do. I'm not going to put you in the hospital if I don't believe that the reason that you're thinking of ending your life is not the result of mental illness, because that's what is required by state law for me to commit you. Yeah. What I can't do is participate in any way, shape, or form in those plans. And yeah. The other thing I would say is, if you're asking me, then you want to talk about it.
Yeah, I agree. So in my practice, I give my patients a copy of the DC Mental Health Act, and I highlight in yellow the language for the clear and imminent danger element of the statute, and say, this is what I have to abide by, and it's unreasonable to think that I'm going to break the law. But I'm not a nervous Nelly. And we can walk up to this, but if in my judgment you cross a threshold where you're in imminent danger, I have to act.
But remember what the DC law says, and every law says, if you're in imminent danger by reason of mental illness.
That's true.
And that's how I think you can get around people who are rationally, because there's state laws that allow people to do that. So it's not an irrational, it's not a symptom of mental illness if you have a terminal disease with a lot of pain, or a lack of real control over your life. Again, it depends on whether you have family that they might want to be involved in it. Can you talk to your family about this? All sorts of questions you'd have to ask. But I don't think you have to say, sorry, don't talk about it.
How do you send a card or flowers and maintain confidentiality?
You just put your name. Don't put PhD.
Okay.
I mean, I'm not going to say that you should send a card and flowers if this is a client that has been alienated from the parents, and you would think that they really wouldn't want you to send a card and flowers. They wouldn't want the parents to even know to ask who you might be. Again, so much of this, we try to give advice in general, but so much of this is case by case specific.
In CAMS, you're also using reliable validated instrument for suicide risk assessment. There's not much in your talk. In CAMS, we use the SSF for our risk assessment. In the clinical trials, we use 19 other measures because that's the nature of a clinical trial, is to use a lot of different measures and different time points at follow-up. What does CAMS training involve time-wise? It really depends on the clinician. You can buy the book, copy the forms, go. You can buy the book, watch the 3-hour online course where it's a demonstration of me working with a really complicated case and be inspired by that and go. You can buy the book, watch the online course, do a day of role play training so you're not doing it for the first time with an actual patient, or you can read the book and get on consultation calls. But you can do a whole different set of permutations.
I just wanted to say that without knowing and never having been through it, I would do the day where you get to role play.
Clinicians hate role playing, though.
Well, maybe, but it's good. It's a good exercise for them to overcome their hatred.
But what we know from the training literature is that clinicians prefer to be trained at, so they can check out their phones and not pay attention and go back to what they always did. Mm-hmm. They don't like role playing, but role playing actually changes clinician behavior, and the coaching calls carry the day. So that's what the implementation science tells us is helps clinicians change their behavior. Purchase the book. There's a lot of CAMS specific things I'm too embarrassed to talk about. Do you charge the family for sessions following a successful suicide? A completed suicide should be the.
What do you think, David? I'll let you go first this time.
I would never do that personally.
You don't, nor would I.
I'm a human being.
People call and say, listen, they haven't paid me for the last 2 months. Should I send a bill to the parents? I mean, what are you thinking?
Yeah, that's not a good way to decrease the anger of the family. During COVID-19 telehealth, could the patient fill out the forms at home, scan them and send them, and we both have a copy? The way that we've done this, and it's all on the Camscare website, available for free, and we have free videos you can download if you want, and all the resources and materials that we've developed. We wrote a paper about this that was published on Fast Track in June. You send the patient a copy of the SSF, and you have a copy of the SSF. So Eric's my patient. He's looking over his copy. He's filling it out, and I'm filling out mine. Eric keeps his for his own reference and use. Mine becomes the medical record. So that's how we're doing it in the pandemic. And it's really actually gone much better than I could have imagined. We now have a PDF version of the SSF that can be exported into the electronic record. And we do have this Microsoft pending electronic SSF that can be done on a Microsoft Surface. Confidentiality continues after death, right?
Yes.
The jurisdiction. I thought it depended on the jurisdiction.
Well, no, it did in almost every jurisdiction except Georgia.
I thought Pennsylvania too.
Well, maybe Pennsylvania also. I haven't memorized all 50, but in most states, the legal representative of the estate becomes the patient as far as getting records and sharing information. Whether you do or not is another question. It depends on the circumstance.
Yeah, this is a very simple question. How do we talk to families as you're suggesting that there's confidentiality after the death?
Because I would say basically you got to choose between not being a human being and the confidentiality law. Nobody that I've ever counseled who has talked to the parents after suicide without, you don't have to. You can talk to the family without giving out a lot of details about what the patient was thinking. And some of it depends on whether you think the patient would want you to talk to the family, but most situations, I think the patient would. And it's like going to the funeral and everything. If you don't do that, you're not being a good caretaker in my judgment. And I think you're increasing your risk. Think about, is a family member going to file a complaint with the board about violating the confidentiality of a deceased patient when you thought that talking to the family would be supportive and you have a note to that effect? I don't think so.
You know, there's a paper that I need to locate. It was done at Johns Hopkins of doctors, physicians that apologized to family members.
Yeah.
And the data that's coming up, some of the data you're probably referring to was, you know, that families don't then move in that direction. Typically, I think was the takeaway.
Mm-hmm.
A formerly suicidal patient moves away, and every so often, every 2 months, say, does a check-in via teletherapy. Psychologist is licensed in a new state. Would Dr. Harris not recommend the arrangement in terms of risk? What's the interjurisdictional thing these days with telehealth?
Right now, because of COVID, this is the longer answer than we can really do right now. But COVID, most states have basically loosened up their out-of-state practice situation. And my sense is, if the patient has moved to another jurisdiction, the only way you would do check-ins is if they have a therapist there and you have access to that therapist. I wouldn't just do check-in sessions with somebody who doesn't have any other treatment in a foreign state where you really can't do anything. The legality of whether you can work across state lines is, let's just say, very unclear at this point. But there has not been any examples of anybody who works across state line with someone who needs them to work across state line, where there's a really good reason for it and it's a temporary thing and it meets the patient's needs. There's no evidence that anybody's ever gotten in trouble for that. One of the court cases in the Federal Court of Appeals was said basically, a physician needs to be able to do more than provide enough aspirin for the client to get to the next jurisdiction. Meaning that it isn't good policy to say, and there's a case where somebody tried to sue people who were doing follow-up. There was an Illinois headache center, and the woman was from California, and she tried to sue them in California, and the court said, no, it's not, we're not gonna have a policy which says you can't get follow-up. People are never gonna do follow-up care, which is really necessary, if we say that they're going to be subject to malpractice or licensing board complaints.
Eric, what's your feeling? It's a huge topic about self-harm behaviors, cutting, burning, self-mutilation.
I'd like to know what your position is.
Well, there's an overlap between self-harm behavior and suicidality. There's increased risk for people that do self-harm to become suicidal. I once, many years ago, had a patient who cut herself, this way on her arm because she was in a dissociative state, then realized how awful her life was and turned the blade and made a near lethal cut. So these are not orthogonal constructs, obviously. A lot of times self-harm behavior gets misinterpreted as suicidal behavior when it's really emotion regulation or dissociation related.
But if you, go on, sorry.
Well, and so it's complicated, obviously.
Well, right. And I think what Tom Joyner says is sort of the principle I go by, that any kind of self-harming behavior is a rehearsal of sorts. Even if they're doing it partly for other reasons, the more you're able to do damage to your body by actual practice, the more susceptible you are to actually going the next steps. It's very hard to kill yourself.
It is.
To overcome it. So what I always say is, well, if they bought the rope and they have their preferred mean is to kill themselves, or if they're going to cut their wrists and they're cutting and they say, oh, I'm just cutting because that's the only way I can feel something, I'd be a little nervous.
Well, there's a habituation effect.
Yeah.
I mean, so Thomas is a good friend of mine. One of his positions is that there is no impulsive suicide. That every suicide is, even if it appears to be impulsive, or the circumstances seem to be to make it seem impulsive, that there's always been a prodromal, previous ideation, and that was one of our arguments in that crisis editorial that we wrote was, the idea that that there's a sudden suicide, and there are suicidologists that feel strongly that they're impulsive, out of the blue suicides, but it seems to me that if ideation isn't on board at the time of their death, the medical examiner calls it an accident.
Well, yeah, and what I would say that is there's no theory describes every situation.
True.
So I suspect that there are some impulsive suicides, but I suspect they're much less infrequent than we think they are from our therapeutic perspective, because we don't often, I think also because a lot of times people don't do they don't do the question and answer kind of thing that gets the information they need to know that there's been thoughts and rehearsal before.
Question about CAM's documentation for Spanish-speaking patients. We actually have done a clinical, a very rigorous back translation to Spanish. There's no book translation in Spanish yet. There's translations to, I think, 6 or 8 other languages, and we just got a contract for a Russian translation for the 2nd edition. Next year, I'll be on sabbatical. I'm writing the 3rd and final edition of the Guilford Press Managing Suicidal Risk book. And so hopefully that will be translated in a bunch of languages as well. So we've seen, we've literally trained CAMs. We've done 3-4 trainings in China. We've done a series of trainings in Australia. I did a training in Uruguay. We've done a half dozen trainings in Lithuania, which is the highest suicide rate in Europe. And this is not to brag, it's just that there's very little competition. Outside of dialectical behavior therapy, the cognitive therapy interventions, there's some interest in ASIP, which is the Attempted Short Intervention Suicide Program, which is a 4-session intervention developed by a Swiss psychiatrist named Konrad Michel. It's a fantastic intervention, but it's got to be replicated to really be good. Mentalization-based therapy is fantastic. There's one psychodynamic therapy developed by Nav Kapoor's group in the UK, but we really need replication to say these things are really reliable and consistent in their findings. Jenna, I'm feeling like I'm not getting more text from you. Eric, do you have any?
I've sent probably about 100. Do you not see 100?
I think my phone overloaded.
Oh, okay, okay. Well, I can read some out loud to you. We've got about 3 more minutes.
Okay, fire away.
All right. So, what about the correctional system? Does CAMS work in the correctional system?
Yeah, it's tricky because the side-by-side seating is tricky. Use of a pen can be weaponized. So what we've done is really move to a telehealth model. And we've trained hundreds of psychologists in California, which is one of the largest penal systems in the country. What I find so interesting is that there are clinicians who are trained in that California system who really don't like the idea of like sitting next to the convict or the inmate, of kind of having this equal relationship. They want to have a authoritative relationship over the patient. So they're not good candidates for CAMS as providers. But then we had this one PsyD student who just gotten out of graduate school, who had this very complicated case of a guy where everybody rolled their eyes when she said she was going to work with him, because he'd be in and out of the hospital ward, the prison hospital ward. And she literally did CAMS by going to the visiting room and putting the SSF up on the plexiglass window, no confidentiality, and doing this on a phone with this guy. And it was transformative in this case. We want to write this case up. I've lost track of her, but we don't want to write this case up because nobody could believe that this inmate was so responsive to the intervention. A question came up about self-harm and attempt behaviors. We have trending data. CAMS may not work for everybody. We have 3 ongoing trials and about 2 or 3 more on the drawing board. So we'll get the definitive attempt data. There's a meta-analysis that's been conducted on CAMS. There's trending data in support of CAMS for self-harm and attempt behavior, but really its sweet spot is ideation, which is a lot of people, and overall symptom distress and depression, and retention to care. And the fact that it's so easy to use and it's flexible.
And I would say there's a good way to close is nothing works for everyone,
no.
But from a risk management point of view, using CAMS will always be protective or using other technique. You can do, if you have good records and good consultations and good informed consent, and you can show in your records that you are a good and caring person, then that will protect you.
Yeah, and our motto at Camscare is best possible care. So whether that's with CAMS or with other proven interventions, that's what we recommend. That's good for your patients and it's good for your malpractice liability.